Welcome back to this second symposium for the day. This will be on MOG, IgG associated disorders or MOGADs. And the first presentation will be on immunopathology of MOGAD. And I would like to invite Professor Kazuo Fujihara to deliver his lecture. He doesn't need any special introduction. He's a true friend of Sri Lanka. He's currently the president of the Pan-Asian Committee on Treatment and Research in Multiple Sclerosis, or SLCTRIMS. Over to you, Professor Fujihara.
Thank you very much for the kind introduction. Hello, everyone. I'm Kazuo Fujihara from Japan. In-person meeting is really important, as you all know, to promote interactions with other colleagues and active discussions, and it may generate new collaborations. But for me, in-person meeting is also important to buy a high-quality Ceylon tea. As you all know, every time I come here, my wife Kanai tell me to buy large quantities of high-quality Ceylon tea. So the sessions of this meeting will end tomorrow afternoon, but for me, another important session will start. I will go out to town to buy Ceylon teas to make my wife happy. But anyway, I would like to talk about immunopathology of MOGAD. These are my disclosures. Since I'm the first speaker of this symposium, I would like to mention a little bit of the epidemiological facts of MOGAD. So as you see here, unlike MS and NMOSD, there's no apparent female preponderance, and it can occur in all age groups, but on average, the age is about 30 years old. And as for prevalence, as you see on the left-hand side, we recently published a review article on epidemiology of this disease, and the prevalence ranges from 1.3 to 2.5 per 100,000, which is much lower than that of MS, especially in Western countries. And annual incidence ranges from 3.4 to 4.8 per million. And unlike MS, there's no obvious latitude gradient, racial preponderance, or strong HLA association. However, in about 20 to 40% of the cases, the disease onset might be post-infectious. Not a single infection is quite important. One of the new entries might be the COVID. After COVID, some patients may develop optic neuritis or myelitis or ADEM-like symptoms. But a variety of bacterial and viral infections have been reported as post-infectious MOGAD. And compared to the aquaporin 4 IgG positive NMOSD, coexisting autoimmune antibodies are much, much less. But one report from Mayo Clinic showed that about 7% of MOGAD patients may have NMDA receptor antibody. So you may need to test NMDA receptor antibody in some of your patients. Recently, we published a 10-year follow-up of MOGAD in comparison with AQP4 positive NMOSD. Interestingly, in comparison with the relapse rate in the first 5 years, in the second 5 years, there was a significant reduction of relapse risk. But like many things in our life, there are exceptions. Some patients who have been followed for more than 10 years had their first relapse after 10 years of onset. So you should be careful. So myelin oligodendrocyte glycoprotein, or MOG, is a minor protein expressed on the outermost layer of myelin sheath. And although the functions has not been fully understood, but it may contribute to the adhesion, cell adhesion, and compaction and maintenance of myelin. And as you all know, in the past, there are numerous reports on MOG-IgG using ELISA and Western blotting, but those results were very much confusing. More recently, cell-based assay have been developed, and then we are able to detect a unique group of patients by a number of different groups across the world. So these clinically meaningful MOG-IgG detects the conformational structure of MOG expressed on the cell surface. So that's important. However, in any assays like this, you should be careful about false negatives and false positives. You should always be very careful about it. So as for the cytokine situation, as you see here, during acute phase in the cerebrospinal fluid, there was a significant upregulation of IL-6, GCSF, IL-8, and other Th17-related cytokines. The levels between MOG and AQP4 were not different. But as you see here, in comparison with MS, the levels in MOGAD and NMOSD are very high. And recently, 2 international clinical trials for relapsing MOGAD are going on. One of them is rozanolixizumab, which is a neonatal Fc receptor monoclonal to inhibit recycling of the antibodies. So as a result of the treatment, MOG-IgG level in the blood will become quite low. And another one is a satralizumab trial, which is meteoroid, and because the IL-6 is very much upregulated, suppressing IL-6 signal may be effective in preventing relapse. But in addition to the relapse prevention, IL-6 receptor blocking therapy may be effective in the acute phase. Here's a report of 2 cases from Professor Brenda Barnwell of University of Pennsylvania. I do not go into the detail, but these 2 boys developed life-threatening, very severe encephalopathy, and they were unresponsive to IV methylprednisolone, IVIG, and the plasma exchange. By the way, these 2 boys were clearly positive for MOG-IgG in the blood. And then they treated these boys with 2 doses of tocilizumab, IL-6 receptor monoclonal antibody. And so these are the acute phase MRI findings. You can see the multiple white matter and the gray matter lesions, and the brain is very much edematous. And brain herniation was imminent in those patients. But after the tocilizumab therapy, there was a dramatic response. So IL-6 receptor blocking may be effective as an acute phase treatment. As for cell damage biomarkers, as we reported previously, CSF myelin basic protein is quite high in this disease. And in this case, developed optic neuritis and longitudinally extensive transverse myelitis. So clinically, this patient was diagnosed with NMO. But unlike AQP4 positive NMOSD, in this patient, CSF GFAP level was below detection limit, while CSF myelin basic protein is very high. So the MOG-IgG positive NMO is not astrocytopathy, but a demyelinating disease. In the lower panel, I show you the data of international collaboration. So GFAP is not increased in MOGAD at all, which is unlike AQP for positive disease. But MVP is quite high. In this study, the MVP level in MOGAD was higher than those in MS. Other groups also reported other biomarkers, serum biomarkers. Tau was higher in relapse than in remission, and the neurofilament light chain in the blood and tau correlated with disability, EDSS scores. And another group reported serum NFL levels in children with MOGAD and other disorders, and neurofilament light chain in the blood were significantly increased in MOGAD and other diseases in comparison with controls. So neuroaxonal damage does occur in MOGAD, although it may be milder in comparison with MS and AQP for positive animal spectrum disorders. So let me move to a histopathology of MOGAD. As you can imagine, so far the histopathological data of MOGAD has been collected mostly from the analysis of the biopsied brains. So as you see here, many of them had relatively large cerebral lesions. It could be diagnosed as a tumefactive demyelinating disease. To exclude the possibility of brain tumors, they were biopsied. On the other hand, MOGAD can develop optic neuritis, myelitis, and so on. But the histopathological data of optic neuritis, myelitis in this disease are still lacking. So these are the findings in the brain lesions, especially the large brain lesions. So this slide shows the various types of demyelination. And this A is a confluent demyelination seen in MS, but this case is a secondary progressive MS. But B is a so-called perivenous demyelination seen in ADEM. As you know, ADEM is a type of clinical phenotype of MOGAD. And you can see numerous small dots or areas with demyelination. This is very specific to ADEM. And the C is Baylo's concentric sclerosis. Demyelination, normal myelin, demyelination, normal myelin, demyelination. And D is a MOGAD finding. And in the lower portion, you can see a numerous perivenous demyelination, but in the upper portion, they became confluent. So this is a combination of perivenous and confluent demyelination. These are the KB staining for the myelin staining. And so perivenous demyelination seems to be relatively unique to MOGAD. This is a higher magnification. This is a small venule, and you can see cell infiltration and demyelination. And macrophages, shown in brown, are infiltrating in the lesions. On the other hand, so Chavero-Montalban already talked about slowly expanding lesion, which is relatively specific to MS. And here's a slowly expanding lesion in secondary progressive MS. And at the periphery of the lesion, you can see a myelin phagocytosed macrophages. And this slide shows the characteristics of the demyelinating lesion in MOGAD. So this is MOG staining. By the way, these are the serial sections. MOG staining and MOG staining. And TPPP is oligodendrocyte staining. So MOG is extensively lost. However, MOG staining is relatively preserved. So MOG loss is dominant. And on the other hand, well, GFAP, AQP4 restored, actually it's activated, so it's quite different from AQP4 positive NMOSD. And this slide shows the astrocytopathic lesions in AQP4 positive NMOSD. This is MOG and MAG and TPPP, and unlike MOGAD, myelin staining is relatively preserved. MOG staining is relatively preserved, while MAG staining is extensively lost. So this is a striking difference between the MOGAD and the AQP4 positive NMOSD in terms of the myelin loss. And GFAP and AQP4 are extensively lost, which is a unique character of this astrocytopathic disease. And what about complement deposition? On the right-hand side, here's a dense deposition of C9neo in the perivascular regions. C9neo is activated complements. And you see the loss of acrolein-4 in the perivascular regions, but in those regions, there's a dense deposition of C9neo. And it is known that complement-mediated cytotoxicity is one of the major pathomechanisms to destroy astrocytes in AQP4 positive NMOSD. But on the other hand, in our study, there are much less remarkable complement deposition in MOGAD. Although in some severe cases, there may be some complement deposition, but in comparison with AQP4 positive disease, there's a striking difference. So here's a comparison of histopathology of MOGAD, MS, and AQP4. So MOGAD and MS are essentially demyelinating disease, while AQP4 positive NMOSD is essentially an astrocytopathic disease. As for demyelination pattern, so as I said, MOG is characterized by perivenous demyelination, while MS is characterized by confluent demyelination. In NMOSD, demyelination is probably the secondary event. As for T cells, CD4 dominant lymphocyte infiltration is seen in MOGAD and AQP4, but in MS, dominant T cells are CD8 rather than CD4. And also, neutrophils and eosinophils may be infiltrated in MOGAD and NMOSD, while in MS, such findings are quite rare. Now, let's move to complements. A few years ago, a group from Australia reported the increased levels of proteins indicative of classical and alternative complement activation pathways, and many of those proteins are increased in MOGAD in comparison with AQP4 positive NMOSD or MS or control. So they concluded that there was a significant increase of the proteins related to classical and alternative complements in MOGAD, and those findings may have therapeutic implications. But those are the data in the blood. And last year, Kevin O'Connor's group at Yale University analyzed the pathogenicity of MOG-IgG in detail and in vivo. And they demonstrated that complement-dependent cytotoxicity and antibody-dependent cellular phagocytosis, ADCP, and antibody-dependent cellular cytotoxicity, ADCC, all operate in MOGAD. However, as I showed you last year as well, Marcus Randall's group in Innsbruck recently reported that complement-activated cytotoxicity, although it does exist in MOGAD as well, but in comparison with AQP4, it was much, much less in MOGAD. So complement inhibition treatment is highly effective in preventing relapse in AQP4 positive NMOSD, but its significance in MOGAD may be less remarkable. Well, we do not know everything, but immunopathology of MOGAD may be summarized as follows. As for genetic susceptibility, well, we do not know, but more detail, maybe genome-wide examination may be necessary to provide evidence. But at some point, there must be a breakdown of immune tolerance, and then MOG-reactive T cell are generated, and then they stimulate the production of MOG-IgG from B cells in the periphery. And as I mentioned, 20 to 40% of the cases had post-infectious disease onset. So there may be triggers of disease onset by infection, vaccination, or other stimuli. And that trigger activates the MOG-reactive T cells and blood-brain barrier penetration. And as a result, inflammation occurs. As I mentioned, Th7-related cytokines are very much upregulated, and the T cells are mainly CD4 cells. And of course, the pathogenicity of MOG-IgG is important in developing lesions, but as I mentioned, in comparison with AQP4 positive NMOSD, complement-dependent cytotoxicity's role may be less remarkable. But again, ADCC, ADCP, and possibly other mechanisms may operate to cause demyelinating lesions. As for the pattern of demyelination, perivenous demyelination is relatively unique. But as I mentioned, those are based on the results of the biopsied brain. We do not know if this pattern is also seen in optic neuritis, myelitis of MOGAD. As I showed you, some lesions showed MOG dominant loss, suggesting that this immune attack is directed against MOG rather than other myelin antigens. And in the chronic phase, broken MOG and other myelin debris are to be phagocytosed by macrophages. And in some patients, autoimmunity to MOG may persist and cause relapses. With that, thank you very much for your attention.
Thank you, Professor Fujihara, for that excellent account on immunopathology of MOGADs. We can entertain questions now, as we are well on time with the time schedule for this presentation. Yes.
Well, thank you very much for this very clear presentation. It's becoming really clear the complement is very much involved in the MOGAD pathogenesis. I think there is some experience, preliminary experience with anti-complement medications such as seculizumab, ravulizumab, etc. Is there any phase 2-3 trials going on nowadays?
In MOGAD?
In MOGAD?
To my knowledge, no.
Why is that?
Well, I think I emphasized that complement-dependent cytotoxicity does operate in MOGAD, but in comparison with AQP4 positive NMOSD, much less remarkable. So there's a doubt if anti-complement treatment is really effective in preventing relapse in MOGAD. Although in some severe cases, complement deposition was seen. We also have one case with severe MOGAD in which the complement deposition is very dense. But generally speaking, compared to the AQP4 positive NMSD, complement deposition is much, much less in MOGAD. And as I introduced, Marcus Randall's group reported that complement-dependent cytotoxicity is, although it does exist, but it's much less than AQP4 positive disease. That may be why companies are not willing to embark on this kind of clinical trials. Yes. Yeah, Peter.
Thank you very much, Kazuo. Excellent as always. In terms of the role of complement, the system obviously contains also a host of regulatory factors.
Yeah, yeah.
And there are diseases where there is a relative deficiency of these regulatory factors. Have they been explored in MOGAD and NMOSD?
Well, first of all, so as I showed you, Australian group reported proteins indicative of complement activation in the blood. So we really need the data in the cerebrospinal fluid. And as for the complement inhibitory factor, we searched for the references, and in comparison with astrocytes, in myelin or oligodendrocytes, those inhibitory factors may be more active. So that may make a distinction between the NMOSD and the MOGAD. But in the study done by Marcus Randall, they used HEC cells for both AQP4 and MOGAD. And they still showed a difference in terms of the complement-dependent cytotoxicity. So that's not related to cell types. But again, we need data in the CSF, and more studies should be done to clarify this issue. Thank you.
Professor Lekha, Pandit.
Yeah, I had a quick question, Professor Fujihara.
Yes.
Yeah. So immunopathological differences, subtle differences between MOGAD and AQP4 IgG-associated disorders, like you mentioned. Could you explain why rituximab may not be so effective in MOGAD as opposed to AQP4 antibodies? Would there be an immunopathological mechanism?
Well, that's practically a very important issue, and I do not have a very good answer. But overall, especially if it's introduced in the after first attack, rituximab treatment resulted in the reduction of relapse rate. That was shown by maybe 2 international studies. But as you mentioned, in comparison with, unlike AQP4 positive NMSD, even if B cells appears to be relatively completely depleted, maybe 60 to 70% of relapses of MOGAD occur under that condition. So that may mean that pathogenetic contribution of memory B cells may be a bit smaller in MOGAD in comparison with AQP4 positive NMSD. But why is that? At this point, I do not have a very good answer.
Thank you.
Thank you.
Thank you very much, Professor Fujihara, for that account on immunopathology of MOGAD. Now I invite Dr. Senaka Bandusena, my co-chair, to take you through the next 2 presentations. Over to you, sir.
Thank you, Harsha. Yeah. Our next speaker will join us virtually. Is he connected? Yeah, he's Professor Ho Jin Kim, He's the principal scientist, head of Department of Neurology. He's also the professor, Department of Cancer Biomedical Science at the National Cancer Center in Korea. And he's going to talk to us on new diagnostic criteria of MOGAD, the validation and challenges. Over to you, Professor Kim.
Thank you for the kind introduction. Do you hear me well?
Sorry, we can't hear you yet. Technical stuff.
It is on. Do you hear me?
Is he on?
Yeah, do you hear me now?
Professor Kim? Professor Kim?
Shall I start?
Is it recorded?
Do you hear?
Until we get the technical thing sorted. Is it sorted? Maybe.
Shall I proceed?
Yeah, you can ask questions. Yes, you can.
Audience?
Yeah.
Can audience hear me now?
You,
Dear Chairman, do you hear me well?
sorry. All right. Can I ask a question from you until, yeah. In MOGAD, like in MS, is there like a subclinical progression, like without relapses, relapse independent, or is it only relapse related to understand?
Well, that's an important question, and essentially, the disability of MOGAD is based on attack. As so far, we have not identified the chronic progressive process typically seen in multiple sclerosis, but we may need to do more examination, not just the clinical observation, but also the other technology already mentioned by other speakers in the previous symposium. But generally speaking, disability of MOGAD is driven by attacks. So relapse prevention is important.
Thank you. Is the sound coming yet or not? Maybe I can ask another question then. Huh? All right. Okay. Sorry. We can. Excellent. Sorry. Yeah. We want the third talk. Is the third speaker? Second.
Yeah. Professor, can you talk?
Yes, shall I proceed? Is everyone able to hear me well? Shall I proceed? Please give me a signal. I don't know whether you can hear me well or not.
Professor, you can proceed.
All right, thank you. Good afternoon. It's my great pleasure to participate in this meeting And first of all, I'd like to apologize for not being able to make in-person talk. I was told to speak about the new diagnostic criteria of MOGAD. For the sake of time, I will just jump into my talk. These are my disclosures. This is today's content and the flow of my talk. I will start with brief background and talk about the key element in the diagnosis of MOGAD. And we'll talk about the issue about the assay, and followed by clinical characteristic features. And I introduce some validation studies that published so far, and I share with some case vignette and wrap up with challenges and future directions. Actually, I set my talk quite simple and easy, so you will follow quite easily. So starting with the history of MOG antibody, the historical scientific interest in MOG antibody traced back to early 2000, when the detection of MOG IgM through Western blot was proposed as a biomarker to predict CIS, conversion from CIS to definite MS, as well as for a marker for early inflammation in MS. However, it didn't take a long time to disappoint us. Subsequent studies employing similar testing assays with denatured MOG protein showed MOG IgG was not actually disease-specific. It was detectable with similar frequency in patients with MS, other demyelinating CNS disorders, and even in healthy controls. And there was lack of association between anti-myelin antibodies and progression to MS. A pivotal study in 2007 by Kevin O'Connor's group nicely showed the assays expressing MOG in its three-dimensional conformation form as opposed to linear epitope, identify a subset of conformation-sensitive MOG IgG in a patient with ADEM or optic neuritis, but not in patient with MS. A subsequent study using cell-based assay expressing human full-length MOG, this is the assay what we are using now, confirmed the detection of MOG IgG in patients with non-MS demyelinating CNS disorders, including substantial proportion of patients with seronegative Euromy's optica spectrum disorders. It is now recognized the spectrum of clinical and MRI manifestations associated with MOG IgG extends beyond the NMOSD phenotype. And according to the clinical imaging and histopathological findings, it is clear that MOGAD is a distinct entity from MS and NMOSD, which prompted us to establish formal consensus diagnostic criteria. And this is the product which was published about a year before. So this long journey started with 6 adult neurologists, highlighted here in blue. And we had an online meeting first, and we found we need a pediatric neurologist because MOGAD is really prevalent in children. And then we also invite Jeff Bennett, who is an expert in neuro-ophthalmology. So this steering groups invite international panel members with the intent to create 4 different working groups here. The panel members were selected to ensure equal gender representation of both pediatric and adult clinicians and scientists, and diverse geographic distributions. So a total of 70 meetings over more than 2 years was held, including 13 steering committee meetings and 5 working group meetings. Each working group defined literature search criteria and a shared reference library, and then present their data to full panel for discussion. And this takes 5 sessions for each group. And then we had a weekly meeting of the full panel, which is held 29 times, which makes the final manuscript. So first manuscript was submitted, then we got the first review, and we need another 4 sessions for resubmission. And the second, after second review, we had another 4 sessions. So it was really long and wide journey. So this is a snapshot of our full panel meeting. And notably, everyone has a different or in different time zone. And here in Sydney, it's very late at night. I spent almost all my Friday night for the 2 years period. But luckily, fortunately, there was a COVID era, so I was not able to go abroad. So it was okay to have this meeting every Friday night. So I can skip this epidemiology because it has been already told. So among the various clinical presentation, as you can see here, the optic neuritis is by far the most common onset feature, particularly in adult, while the ADEM with or without concomitant optic neuritis is the typical first manifestation in children, particularly before the age of 11 years. Another important thing is MOGAD can exist as either a monophase illness or lapsing disease. This makes a big difference in terms of management and treatment choice with other 2 important differential disease, such as multiple sclerosis and aquaporin 4 antibody positive neuromyelitis optica spectrum disorders. So in order to make a diagnosis MOGAD, it is imperative to fulfill these 3 key criteria. So patients should have at least 1 core clinical demyelinating event. Here I showed 6 core clinical events, and one need to confirm the presence of MOG antibody using validated assay, and one need to exclude for barrel explanation, which is also true for multiple sclerosis and even for NMO spectrum disorders. But most of the issues raised from the MOGAD IG testing, because this test shows quite a big assay variability. So one international multi-center blind comparative study showed quite a frequent discordant result, particularly in low positive samples. Another caveat, even more troublesome, is presence of false positivity. So MOG-IgG can be detected in patients with clinical, radiological, and CS findings diagnostic of MS up to 2.5%, even in healthy individuals. So although fewer than 2.5% of patients with MS would test positive, the absolute number of false positive result that would result from routine screening for this assay in adult with MS would be really, really high. So you will end up many numerous false positive result. This is the reason why the panel actually set the tiers for the antibody positivity. So if one proved the positivity of over the titer of 100 or FACS ratio more than 1.5, or at least 2 doubling dilution above assay cutoff, it was defined as clear positive, then you need only core clinical criteria. But any other positive result below this cutoff was defined as a low positive. Then you need both core and supportive criteria. So here is some example for positive predictive value for this assay. The frequency of MOG-IgG approaches more than 50% in children with optic neuritis or ADAM, particularly children younger than 11 years. While the frequency of MOG-IgG in adults with optic neuritis, although this is most common manifestation, is only around 5%. However, the frequency of MOG-IgG in adults with optic neuritis with severe optic disc edema, which is one of the characteristic feature, is substantially higher than in adults with retrobulbar optic neuritis. So with regard to MOG-IgG assay, the live cell-based assay that use full-length human MOG quantified by either flow cytometry or microscopy is recommended. And with regard to secondary antibody, IgG-Fc or IgG1 was mainly recommended, while if IgG heavy chain secondary antibody, if externally validated in-house assays are used. Fixed cell-based assays such as Eoin kit are a reasonable alternative when live CBA testing is unavailable. Serum is a preferred specimen because CSF alone provides very low sensitivity for this test, but a small number of patients with immunology disorders were positive for MOG-IgG in the CSF alone. So therefore, CSF testing for MOG-IgG can be used in a very selected circumstances to support the diagnosis of MOGAD in MOG-IgG seronegative patient with supporting clinical MRI features. So this is the key table of the, I believe you may already be quite familiar with this. So one need at least one of the 6 core clinical characteristics. Then if antibody is clear positive, you don't need additional supporting features. Avoid this low positive or positive without titer, which is quite common, and negative but CSF positive. You need to confirm the aquaphorine IgG seronegativity and at least more than one supporting clinical MRI features. Also, you need to exclude barrel diagnosis, particularly multiple sclerosis. So these are the supporting clinical MRI features, and I'm going to delve into these things one by one. Starting with optic neuritis, this is the most common presentation in adult. And as you can see here, optic disc edema is quite common and can be associated with hemorrhage. Bilateral optic neuritis is common at onset, and visual loss is often worse than 6/60 and later. Nevertheless, recovery was quite good following. And on MRI, the longitudinal extensive lesion, which are more than 50% optic nerve, is characteristic features, and perineural optic sheath involvement is quite a unique feature in MOGAD as compared to other optic neuritis. So these 4 red consist of supporting clinical MRI features for optic neuritis in MOGAD. And with regard to clinical cause, relapsing optic neuritis, it can be seen in about 30 to 50% of patients with MOG-IgG. Moving on to myelitis in MOGAD, it can occur in isolation or as a component of ADEM or concurrent with optic neuritis. LVTN, which is actually the hallmark of NMOSD, can also seen in more than 60% of MOGAD myelitis. But short regions also occur, and sometimes you may see multiple small code regions at the same time, which is not common in NMOSD. Attack severity varies, but it's typically moderate to severe. So over 50% of patients shows greater than 4 EDSS scores. The recovery is usually the motor recovery is usually good or excellent, while permanent bladder, bowel, or sexual dysfunction can occur. The carnosic environment is most common in MOGAD, so this also is part of the supportive clinical and MRI features, and it often involves central gray matter and selective environment, which made so-called H signs, as you can see here. And recurrent myeloid episode without demyelination elsewhere in the CNS are rare, which is contrasting feature of relapsing optic neuritis in MOGAD. So follow MRI is quite informative. You may see complete resolution of caudal region in MOGAD, which is not common in MS and NMOSD. And up to 10% of spinal cord scan can be normal at onset. The brain and brainstem involvement in MOGAD positive patient can present with ADEM, cerebral cortical encephalitis, or brainstem or cerebral symptoms, or sometimes only clinically silent brain or brainstem lesions in patients with clinical optic neuritis or myelitis. So ADEM is the most prevalent clinical syndrome at presentation in children with MOGAD IgG, and the antibody was are detected in around 50% of pediatric patients with ADEM. Again, the complete or almost complete clinical and radiological resolution occurs in over 50% of children in MOGAD associated with ADEMs. So outcome can be poor in rare cases of children who develop of leukodystrophy-like brain imaging patterns. And we just heard that really devastating cases can occur in children with MOGAD from the former speakers. And relapses following ADEM occur more frequently in seropositive patients than in seronegative patients. Cerebral cortical encephalitis, which is also referred as FRAMES, flare hyperintensity regions in anti-MOG encephalitis with seizures. Seizure can be the first manifestation with more typical demyelinating presentation later in the disease course. Although rare, raised ICP can occur and can be life-threatening. Dual antibody seropositivity can be seen, and these are supporting MRI features for brain and brainstem syndrome. I believe the next speaker will talk much more comprehensively. I'd like to highlight the cortical regions with or without regional or overlying meningeal enhancement is quite unique features for MOGAD as opposed to MS and NMOSD. And again, the complete resolution is a unique feature in MOGAD. So now I'm going to introduce some validation studies. This is the first one published last year from myself, and we actually applied our 100th patient already designated as MOGAD, and 93 fulfilled the criteria throughout the median 24 months of follow-up. Importantly, all 36 patients with clear positive satisfy the supporting features, which forming the high specificity for clear positivity for characteristic features of MOGAD. Here's another bigger and larger study. It's this collaborative study from the international panels to assess clinical performance within 6 months of the first attack in pediatric and other patients with positive MOGAD IgG, and found 97% sensitivity when it was applied within 6 months. This was presented in last year's SLCTRIMS as a poster. This study from UK was published about in few weeks before. And they also found that 97% of patients already designated MOGAD fulfill the criteria. And some misdiagnosis may occur due to delayed testing or insufficient investigation. And they also show the higher specificity of a new criteria as compared to the 2018 international recommendations. This is a smaller study from US published just a few days ago, this January. They also found 100% sensitivity, and they report quite low specificity because of including these 4 patients, CNS vasculitis, primary progressive MS, and pseudotumor cerebri, and bevacizumab-induced anterior ischemia neuropathy. All of them showed low MOGA-IgG positive titer, but fulfilled the criteria based on presence of supporting MOGAD features. So but I think they missed one of the important criteria, meaning the exclusion of better diagnosis. If they have a clear final diagnosis of 4, I think they should exclude this patient from the MOGAD diagnosis. But it is important to highlight the exclusion of better diagnosis. It's really important to make a specific MOGAD diagnosis. So I'm going to share some case which is quite straightforward and simple. This 33-year-old female presented with both eye reduced visual acuity, and she felt eyebrow pain during eye movement about a week before. She presented with reduced vision, which was lowest is 0.2 and 0.5. And ophthalmologic evaluation showed bilateral optic disc swelling like this. And MRI showed bilateral optic nerve enhancing region at this posterior part, but sparing the optic chiasm. And there was no brain parenchymal regions. And MOGA-IgG test show clear positive result. It was quite clearly positive up to 1 in 100, and FAX ratio is really, really high. And does this patient fulfill the criteria? There was a co-clinical event and clear positive animal result with many supporting clinical MRI characteristic features. And you may not think the better diagnosis for this patient. So yes, this is clearly fulfilled the criteria. And next is 28-year-old female, again showed decreased visual acuity on left eye, and ophthalmology evaluation showed RAPD, but no optic disc swelling. And assay result was positive, but only for 1 in 20, and it was negative 1 in 100. So it was defined as a low positive. And MRI showed focal enhancing region and anterior portion of left optic nerve. But you can see numerous focal white matter regions surrounding ventricle and juxtacortical area and corpus callosum. Then, same questions. There was co-clinical demarcating event. It was low positive, but there was no supporting clinical features. So only with this, it cannot fulfill the criteria. And there's clearly better explanation because the MRI features is very typical for multiple sclerosis. So the answer is no. Moving on to 48-year-old female, again, decreased visual acuity on right eye. Well, it was really severe. She can only detect hand movement. And recovery was also really, really poor despite the acute treatment. And here you see the dense enhancement on posterior part of optic nerve pathway. And MOGA IgG was positive, but only in low titer, and aquaporin IgG was strongly positive. So same thing. There was supporting MRI features. So if you just technically apply this, you may think it can fulfill, but there is no better explanation, which is aquaporin positive NMOSD. So the answer is clearly no. So the dual antibody positive, they sometimes occur, but in my hand, only very strong aquaporin positive with low positive for MOGA antibody, and clinical features are more suggestive of NMOSD, not MOGAD. The last one was 51-year-old May, metastatic renal cell carcinoma, treated with other treatment, but failed. And he was on new trial for immune checkpoint inhibitor, ticagrelumab and atezolizumab combination, which is anti-PD-L1 inhibitor. And this new monoclonal antibody target the T-cell immunoglobulin and IM domain, which is the inhibitory receptor presented on lymphocyte. And he was presented with rim ataxia following the combination treatment. And here you see some such regions on involving basal ganglia and left internal capsules with mild swelling. But there was no diffusion restriction or clear enhancement. So interesting, CSF finding shows mild pleocytosis with increased protein, but cytology was negative. But interestingly, MOG antibody was clear positive. So patient was treated with high dose steroid, which was and respond quite well, and the MRI was almost normalized within a few weeks. So in this case, again, there was co-clinical demyelinating event, and antibody was clear positive, and supporting MRI feature that involved deep gray matter of brain. And well, with regard to exclusion of background explanation, probably there was some debate, but in the context of clear positive, I would diagnose this patient as MOGAD. Well, but still there's some outstanding issues. We need to validate these criteria in a prospective cohort. So far, there was only retrospective studies and some patient. And one of the key issues is some patient will present with clinical and imaging features consistent with MOGAD, but will not have detector MOGA IgG, or will reside in the world regions where reliable MOGA IgG testing is not available. Well, this is a key problem because there is no seronegative MOGAD, unlike NMOSD. So future studies will be needed to identify whether such patients follow a similar disease course as those who have MOGAD defined by presence of MOGA IgG. The prompt identification of relapsing versus monophasic is very important. And with regard to treatment choice and duration and monitoring of treatment response, I think the following speakers will talk more, but this is still the remaining issues we need to solve. With that, I'd like to thank you.
Thank you very much, Professor Kim, for that excellent presentation. In the interest of time, we probably will be able to entertain one question, I should say. Yes.
Well, thank you very much for this very clear presentation. I learned a lot. So how many times should we repeat the MOG antibody test? Because we had a couple of very typical MOGAD patients with negative anti-MOG antibodies repeatedly. And at the end, after the 5th determination, the positive become low positive. So how many times do you recommend to to retest when you have a clear patient?
Yeah, if you think the patient is otherwise typical clinical and MRI feature with MOGAD, I would repeat like you when until I found the antibody. But some borderline patient, if you use validated assay and the sample was taken before the treatment, I would not recommend to repeat that many times. I hope I don't answer. It depends on the clinical situation, I think.
Wants to ask you a question. Over to you.
Hi, thank you so very much, Giancarlo Comi. A question. One of the key points is to try to understand if the patient is going to have a relapse course or not. That's really a fundamental aspect. Do the persistence of antibody be one of the predictive factors for let's say, a relapsing cause, now that you have start to have a long-lasting observation, is this something that you have to take into consideration?
Yeah, that's actually the burning question we want to address. And you are partly right. The persistent positivity from the retro study is the only finding that can predict somehow the future relapses. But there's always some exceptions. Despite the persistent positivity, some patients stay with monophasic course. And the alternative example is also present. Even though patient convert to negative, later patient can have a relapse and then found to be positive again. So this is something really difficult to address, but probably the prospective incidence code study can give you more, firm answers.
Thank you very much, Professor Kim, for your excellent talk once again, and also hope you can stay till the end of the symposium online in case we have time for.
Okay, I will stay as long as possible.
Thank you very much. It's very kind of you. We move on to the next talk, the third talk for this symposium, and I invite Professor Eoin Flanagan. Professor Flanagan is the Professor of Neurology and Chair of Division of Multiple Sclerosis and Autoimmune Neurology from Mayo Clinic, USA. And today, Professor Flanagan is going to talk to us on the radiological features of MOGAD, a very important aspect, I think, for us. Over to you, Professor Flanagan.
Hopefully you can hear me okay there. It's a real pleasure to be able to talk to you again. I'm sorry I couldn't make it in person this year, but I'm delighted to be able to talk to everyone in Sri Lanka there. So today I'm going to talk about the radiological features of MOG antibody-associated disease. Some of this was touched on briefly in the last talk related to the criteria, and we'll delve in a little bit deeper here. Move my slides. These are my disclosures, which aren't too relevant to this talk, which is mostly focused on diagnosis. So when I consider CNS inflammatory demyelinating diseases, I think we have three major well-defined diseases. That's multiple sclerosis with all of its variants, from radiologically isolated syndrome all the way to secondary progressive multiple sclerosis. The second was an antibody-defined CNS disease associated with demyelination, aquaporin 4 antibody-positive neuromyelitis optica spectrum disorder, or NMOSD. And then the third most recent one is myelin oligodendrocyte glycoprotein antibody-associated disease, or what we term MOG antibody-associated disease, or MOGAD. when we're imaging, one of the most crucial aspects of imaging that I'll bring up first is the importance of ordering the right type of image. So optic neuritis is the most common manifestation of MOGAD. And here you can see an example of just a brain MRI without fat saturation. And it would be difficult to tell if there was any optic nerve enhancement. But when you do the correct orbital MRI sequences with fat saturation, you can really see that there's clear evidence of enhancement of the optic nerve in a longitudinally extensive way here in the anterior segment that's very typical of MOGAD. So this could be missed if you order just a brain MRI. So always remember to order the correct test. So if we think about optic neuritis associated with MOGAD, it's the most common manifestation, and up to a third of cases can be bilateral, which is more frequent than we see with MS. It often begins with pain, so there may be a little bit of a therapeutic window where patients will have pain with eye movement, and that might be a time where you could initiate corticosteroids if you were highly suspicious for a relapse. As mentioned by Ho Jin Kim, there can be prominent optic disc edema. So these are patients where you want to take out your fundoscope and look in the back of their eyes because you'll see much more optic disc edema than you see with multiple sclerosis. They also tend to be more severe at the nadir, so a median visual acuity of count fingers, but it tends to recover better than aquaporin 4 antibody positive NMOSD and has similar outcomes to multiple sclerosis. Here we can see a typical episode of optic neuritis. You can see here the anterior segment involved, and sometimes the inflammation will spread into the optic nerve sheath that we sometimes term optic perineuritis, or other times the enhancement can spread into the orbital fatty tissue. Here we see an example of bilateral anterior segment optic neuritis. That's very typical of MOGAD to have bilateral anterior involvement, and it may be that this prominent anterior involvement is the reason why there's prominent optic disc edema. We can sometimes see T2 hyperintensity also within the nerve. That's not really as useful a radiological finding as the enhancement, so we generally focus in mostly on the gadolinium enhancement, which tends to be more reliable and more present in the acute situation. Transverse myelitis can also occur with MOGAD. That can occur in the setting of an acute disseminated encephalomyelitis or ADEM episode, or in conjunction with optic neuritis, or it can occur in isolation. And these episodes, again, tend to be severe, so these patients often have urinary retention, as bowel and bladder impairment is common, and they may have erectile dysfunction. And it can mimic the myelitis of acute flaccid myelitis. And here you can see a longitudinally extensive lesion within the cervical cord, pretty typical, about probably the majority of cases, probably 70% are longitudinally extensive. And then sometimes on the axial sequences, probably in 40 to 50% of cases, it will be restricted to the gray matter and form this H sign. So you might see this H sign here. We can also see sometimes a long lesion and a short lesion. Often they're central, and the conus seems to be also prominently involved. So sometimes when I'm teaching the residents, I'll tell them to look out, depending on their lineage, for the TIE fighter sign or the Under Armour sign to help them remember this pattern. And as Ho Jin Kim mentioned, sometimes the MRI can be normal. I'll discuss this a little bit later on with regard to the brain also, but in about 10% of cases, there can be a little bit of a radiological lag, and sometimes repeating the MRI in 5 to 7 days, you may pick up the lesions, or otherwise doing a CSF, you may see inflammation. And what about the cerebral attacks? Well, we know from the earlier talk by Ho Jin Kim that you can have ADEM as a manifestation, and these patients can have severe encephalopathy, and indeed these episodes can be life-threatening, and you may need mechanical ventilation. And Professor Fujihara nicely covered earlier that some of these patients can be quite fulminant and require acute treatments like tocilizumab in that setting. And some of the characteristic features we can see with the cerebral attacks here, we can see deep gray matter involvement involving the basal ganglia, involving the thalamus, and again, a typical white matter lesion. And the lesions tend to be a bit more fluffy and more ill-defined than we see with multiple sclerosis. Again, here we see some other examples of these fluffy, ill-defined lesions. That differs a bit to multiple sclerosis, where we see these more characteristic ovoid or linear lesions perpendicular to the ventricle, or lesions at the inferior temporal pole are more suspicious for multiple sclerosis. Brainstem and cerebellar involvement can occur. It doesn't tend to occur the way it does with multiple sclerosis, where we'll have an episode of double vision in isolation or an episode of facial numbness in isolation. It tends to occur more in the setting of an acute encephalopathy, usually in the setting of ADEM. And what you'll see on the MRI is that the lesions tend to be larger. So here you can see a diffuse lesion within the pons, which would be very atypical for multiple sclerosis. And we also see quite a bit of involvement in the middle cerebellar peduncles. You can see a large lesion here in the middle cerebellar peduncles, which is pretty typical of MOGAD. You can also have corpus callosum involvement. This is not very specific, but it does tend to be larger than we see with multiple sclerosis. Here you can see prominent splenium involvement. Sometimes you'll see holo corpus callosum involvement, or extension outside of the corpus callosum into the white matter can be typical, and we can see butterfly type lesions here. Gadolinium enhancement is also quite common with MOGAD. So here you can see an example of some leptomeningeal enhancement and also cortical enhancement here in this situation. I will mention that we don't tend to see with conventional sequences leptomeningeal enhancement with multiple sclerosis. Excuse me. Here we can see an example of some other fluffy areas of enhancement, or sometimes we can see enhancement within the brainstem that can mimic the Klippers syndrome that has been reported. So sometimes you'll see these fluffy multifocal regions of enhancement within the brainstem. And again, the enhancement tends to be transient and later go away. As was mentioned earlier, the cerebral cortical encephalitis is a very interesting phenotype of MOGAD, where you get this often unilateral T2 hyperintensity with swelling of the cortex. And sometimes you can also see vascular changes, like we see hyperperfusion here. And we can also see evidence occasionally of leptomeningeal enhancement accompanying this T2 hyperintensity within the cortex. And this was described as FLAMES, which is unilateral cortical flare hyperintense lesions in anti-MOG associated encephalitis with seizures. Here's some other examples of the cerebral cortical encephalitis. You can see here very prominent T2 hyperintensity, very different from the other side. And then you can see leptomeningeal enhancement here. Sometimes these lesions are a little bit more subtle. You can see here the swelling in the cortex posteriorly here, along with T2 hyperintensity and some subtle leptomeningeal enhancement. So it's important to look along the cortex for swelling, as it's not always perfectly obvious. There's also been reports of T2 hypointensity in the adjacent white matter next to that T2 hyperintensity within the cortex. Other areas of involvement, sometimes the inflammation will spread into the cauda equina nerve roots. So you may see some myeloradiculitis and enhancement of the cauda equina. Also, the French group, Dr. Marinier and colleagues and Dr. Copacalvo have shown that there can be enhancement of the cranial nerves. And then, as we mentioned, you can have this meningeal enhancement, and some patients will have more of a meningoencephalitis or an aseptic meningitis type presentation. You can also have increased intracranial pressure, which can mimic pseudotumor cerebri. I will give a brief caution, and this was touched on by Dr. Ho Jin Kim, that you can have low positive, false positive results. So you need to be a little bit careful when there is an expansion of the phenotype. So there may be reports out there that report isolated peripheral neuropathy or progressive myelopathy, primary progressive MS type phenotypes with low positive MOG antibodies. And these may represent false positive results. So you have to be a little bit careful. But one of the ways of telling is if the titer is very high and if patients have other phenotypes that are typical. So, for example, the cerebral cortical encephalitis, many of those patients will have other episodes of optic neuritis, or they'll have other episodes of typical ADEM in association with the cerebral cortical encephalitis episodes. As was mentioned earlier, some patients will go on to develop a leukodystrophy type pattern on their MRI after one or more ADEM attacks, and maybe these patients are more genetically predisposed to damage the white matter. There have also been many studies showing that the brain growth can be inhibited in these patients from these multiple attacks. Here we can see some examples of a comparison of the MRI of the orbit in MOG. Again, we see bilateral anterior segment optic neuritis. With aquaporin 4, the enhancement in the optic nerves tends to be more posterior. And with MS, we have shorter lesions within the midsection of the optic nerve, like we see here. What about tumefactive lesions? They're actually quite common in MOGAD. They probably represent up to 40 or 50% of brain lesions. A tumefactive lesion is a lesion that extends greater than 2 centimeters and is present in about 22% of all MOGAD patients. And here you can see some examples. Sometimes they can be in the deep gray matter or in the middle cerebellar peduncles. With aquaporin 4 antibody positive NMOSD, sometimes we'll see some restricted diffusion, and we can see this arch bridge signal abnormality within the splenium of the corpus callosum. With other tumors, we'll see more homogeneous enhancement, like we see here, and heterogeneous signal abnormality with lymphoma. With glioblastoma, tumefactive lesions will see this craggy enhancement and a large mass effect here. And then with an abscess, we may see some central restricted diffusion. It's interesting in MOGAD, we don't tend to see as much the Bailos type concentric sclerosis. That's much more suggestive of multiple sclerosis, and also complete ring or incomplete open ring enhancement towards the cortex is much more typical of multiple sclerosis. And there are reports in multiple sclerosis that some of the lesions look almost pseudocystic with a rim of hypointensity, like we can see here. And sometimes you'll see an ADC darkening with some DWI restriction in an arc or rim type pattern. And again, all of these features are much more suggestive of multiple sclerosis. So what are the classical lesions of multiple sclerosis? Well, here we'll just quickly go over some examples to help us with our differential diagnosis. So here you can see an inferior temporal pole lesion. We can see typical Dawson's fingers. We can see ovoid or linear periventricular lesions. We can see multifocal enhancing lesions. We can see juxtacortical lesions. And we can see these peripheral brainstem lesions in the dorsal pons here. And then patients tend to have chronic T1 hypointensities. And within the spinal cord, they have shorter lesions, sometimes with a ring of enhancement. There's a nice review from Dr. Ho Jin Kim and a whole bunch of collaborators from 2015 in neurology that highlighted many of the features of aquaporin 4 antibodies, including lesions around the fourth ventricle. There can be lesions around the internal capsule or cerebral peduncle. You can have linear ependymal enhancement with aquaporin 4 positive NMOSD. You can have lesions around the fourth or the third ventricle. We sometimes again see lesions extending up to the internal capsule. You can have this splenium arch bridge appearance of the lesions with aquaporin 4. And then in the spinal cord, we tend to get longitudinally extensive lesions. And sometimes they have a bright spotty T2 hyperintensity within the lesion. And Ho Jin Kim has shown before that we don't tend to see this much with MOG antibody-associated disease. In about 15% of cases of aquaporin 4, we can see a shorter lesion like we see here, and often that's more central and quite swollen like we see here. There have been some studies looking to compare MRIs with between MOGAD and multiple sclerosis. And some of the things that would favor MOGAD are fewer lesions and the lesions being more ill-defined, while what would favor multiple sclerosis is greater than 3 lesions, inferior temporal pole lesions, Dawson finger lesions, T1 hypointensity, and subcortical U fiber lesions. What I will say is that it's actually quite difficult to distinguish radiologically MOG from aquaporin 4, and there's a lot of overlap. Even though I showed some discriminators today, overall there's much more overlap between MOG and aquaporin 4, and it seems to be easier to discriminate from MS. There have been some studies of advanced imaging that found that cortical lesions in the remission phase are less common with MOGAD. most of these studies are done in the remission rather than the attack phase. We know that you can have large cortical lesions like we showed in cerebral cortical encephalitis with MOGAD. And the lesions in MOGAD that we do see tend to be more intracortical. Another thing I'd like to mention is just about the dynamics of the lesions. So MOG antibody-associated disease is very dynamic. So that means that the MRI changes a lot within days to weeks of an attack. So here you see, even within the same attack, this patient first had an initial normal MRI. We see that in about 10% of patients. And then you can see 15 days later, there was evidence of multifocal T2 hyperintensities within the brain. We term this a little bit of radiological lag. So there seems to be some radiological lag. Here we see another example with a couple of lesions here within the brain, and subsequently 16 days later, there's a much more extensive number of lesions within the brain. So the number of lesions tends to change a lot with MOG. We don't see that as much with MS, where the lesions can grow in size over time, but we don't tend to see as much of a change in number over a short period of time, although patients can develop some new lesions. Excuse me. With aquaportin 4, again, we tend to see more stability of the lesions over time. This is a couple of examples here where the MRI remained more stable. So if you're seeing a lot of changes, even some lesions can disappear within one attack, then you're going to think more about MOG antibody-associated disease. And if you're suspicious and the initial MRI is normal, you can repeat it 1 to 2 weeks later, and sometimes you'll pick up the signal abnormalities that weren't there initially. It was mentioned earlier a little bit also. What's interesting about the MOG antibody-associated lesions is they're different from multiple sclerosis. Of course, multiple sclerosis means multiple scars, and MOG antibody disease-associated lesions don't tend to form as many scars. Here we can see an example of multifocal lesions here, and then many of the lesions resolve with just one lesion persisting here. Here's another example in pediatrics of a large lesion in the deep gray matter, and internal capsule disappears completely on follow-up. With MS, we do see a reduction in size. Here we see a couple of acute lesions in MS, and then the lesion is much smaller but tends to persist. And then we tend to get these persistent T1 hypointensities with multiple sclerosis more so than with MOGAD. And here we see in pediatrics, we'll see a lesion here, and then this tends to persist over time, but is slightly smaller in the follow-up imaging. With aquaportin 4, the lesions tend to reduce in size a bit more than they do with MS, but they don't tend to resolve completely, and often will leave some residual signal abnormality like we can see here, or we can see over here in a pediatric patient where there was periventricular involvement and persistent signal abnormality, although markedly reduced in follow-up. Dr. Kazuo did a nice study with us looking at the predictors of T2 lesion resolution and the timing of resolution. And the median time to resolution was 4 months. And some patients will have resolution of their lesions even if they don't get any acute treatment. And that suggests that lesion resolution is part of the natural history. Steroids seem to help promote resolution. We think that edema could be a component of why these lesions resolve, but also perhaps remyelination may also be something related to that. And the cases that had more prominent T1 hypointensity acutely tended to persist. Here we can see other examples. Here we can see a long lesion within the cord in MOGAD, and then in follow-up, the lesion completely resolves. Here we can see with aquaportin 4, a long lesion, and then the lesion persists over time, and there's a little bit of spinal cord atrophy here in follow-up. And with MS, here we see a typical short lesion, and follow-up, the lesion persists and remains in the right lateral column of the cord. Excuse me. And this may play a role in the clinical course. We know with MOGAD that there's no secondary progressive phase. They may have a monophasic or relapsing course, and they tend to accumulate a little bit of disability with each attack, but not so much. With aquaportin 4, we saw prominent atrophy there, and we tend to see prominent disability accumulation with each attack. And then with MS, we tend to get these large persistent lesions, and one could argue that as most patients who progress with MS have a progressive myelopathy, that some of these persistent lesions in the cord may be a nidus for progression. We have seen some patients who progress from a single lesion within the spinal cord, suggesting that these persistent lesions could be a nidus for progression, for that secondary progressive phase that we see with multiple sclerosis. So that's something we need to study more, but a potential hypothesis. Another difference that we have in MOGAD from MS is that in MS, we know our standard is to do serial MRIs over time and look for evidence of new lesions. And particularly before we had the high efficacy treatments, it was quite common for MS patients to have new lesions. In this study, in patients mostly on mild or low efficacy medications, 54% had new lesions over time. And this was much less with MOGAD at 4% and less with aquaporin 4 at 8%. The reasons for this may be that there's less subclinical disease in MOGAD. The lesions tend to come at the time of an attack. Also, we know that in MOGAD, about 50% of cases are monophasic, so those patients aren't going to develop new lesions over time. And then the optic nerve predominance, there are a good proportion of MOGAD patients, maybe 20–30%, that it only involves the optic nerve and never involves the brain parenchyma. And then it's also possible that lesion resolution may play a role. So if you do 2 MRIs separated by 2 years, you may have had lesions coming and going in the interim that you won't see in the follow-up because they've resolved. This does have an impact for our clinical practice. We don't tend to recommend serial surveillance MRIs in these patients with MOGAD. And in clinical trials, one of the major endpoints for MS clinical trials is the development of new T2 lesions or enhancing lesions. And with MOGAD, that won't be as beneficial as we don't tend to see as much of that. So that's something to mention. This was really covered in the last talk, so I won't go over this, so only to mention that many of the features that I've mentioned today, that I've shown today on the images, are included in the supporting features that you need if you have a low positive MOG antibody or if you have a CSF positive or you don't have a titer results. So it's important to be able to look at the radiology and determine what the findings are. So I'd like to kind of go over just a little bit the conclusions of the talk here. So we looked at some of the lesions in MOGAD. So here we can see the typical lesion in MOGAD is a long lesion within the anterior segment of the optic nerve. Sometimes there can even be optic disc edema evident on MRI, and sometimes the enhancement will spread into the optic nerve sheath or the fatty tissue, and doesn't tend to involve the chiasm as much, although can sometimes slightly extend to the chiasm. In follow-up, the enhancement tends to go away, although rarely there can be some persistent enhancement. With aquaporin 4, we tend to see involvement sometimes of the bilateral chiasm when we see bilateral optic neuritis, like we see here, and then in follow-up, the enhancement will often go away. And with MS, we'll see a shorter lesion in the mid-segment of the optic nerves, and then that will go away, the enhancement will go away in follow-up. In the spinal cord, with MOG in the acute setting, we'll tend to see long lesions like we see here, and sometimes involving the conus. And on axial images, you may see this H pattern of T2 hyperintensity. On the post-gadolinium images, you'll see a little bit of enhancement, sometimes extending into the conus or the nerve roots. And then in follow-up, the lesions tend to resolve mostly and disappear completely. With aquaporin 4, we'll see a long lesion like we see here, usually involving the central gray and white matter. And sometimes you'll see an elongated ring of enhancement with aquaporin 4. And then in follow-up, usually there'll be some persistent T2 hyperintensity. There'll probably be more spinal cord atrophy and a little bit of residual signal abnormality, and the enhancement will be gone. With multiple sclerosis, we'll see short lesions here within the spinal cord, usually in the periphery of the spinal cord. And sometimes we can see some enhancement of those lesions. And then in follow-up, sometimes you'll see some focal atrophy, and you may see new lesions accumulate over time, and the lesions that were there will tend to persist, and the enhancement will tend to go away if there was enhancement present. In the brain, here we can see typical MOGAD lesions. You may see these diffuse lesions within the medulla or pons. You may see large lesions within the middle cerebellar peduncles. You can see these fluffy T2 hyperintensities within the white matter or within the bilateral gray matter, like we see here. you can see these T2 hyperintensity and swelling of the cortex with the cerebral cortical encephalitis phenotype. And then we can see also leptomeningeal enhancement, like we see here. And then in follow-up over time, if you did a follow-up MRI in a year, most of the lesions will have disappeared and the enhancement will be gone away. With aquaporin 4, we can see lesions in the around the fourth ventricle, like we see here, or the area postrema, resulting in intractable nausea, vomiting, and hiccups. We can see lesions within the internal capsule or the splenium of the corpus callosum. And on the post-gadolinium images, sometimes we'll see ependymal enhancement. And then in follow-up, these lesions will be smaller, but they'll generally be still present. And sometimes we see some small perivascular T2 hyperintensities also in aquaporin 4, like we see here. With MS, we tend to see more peripheral lesions. Here you see a peripheral lesion within the medulla and peripheral lesions within the brainstem. In the brain here, we can see T2 hyperintensities adjacent to the ventricles here and juxtacortical lesions. And these ovoid periventricular lesions are typical. And then some of these lesions may have a ring, a closed ring of enhancement or an open ring of enhancement is pretty typical. And then in follow-up, these lesions will tend to persist over time, so they'll remain present. And sometimes you'll get development of new lesions like we can see here. So a few new lesions developing over time, particularly on patients on low efficacy medications. We don't tend to see new lesions as much now in the era of high efficacy medications. And then the enhancement tends to go away. So I will stop there and I'll open it up for any questions. I'd like to thank the many people who've worked on many of these studies with me, in particular our neuroradiologists who help us with reviewing these patterns. But I will say that as a neurologist, it's also good to look at your own MRI, as that can be helpful. And I will stop there maybe and open it up for questions.
Thank you very much, Professor Flanagan, for that very comprehensive talk. We have time for a couple of questions. Yep.
Eoin, well, thank you very much for the excellent overview of the MRI findings in MOGAD in comparison with NMOSD and MS. In your talk, you presented some other involvements which are different from current core clinical demyelinating events like mild radiculitis, meningitis, cranial nerve involvements. You also pointed out that you should be careful about expanding the core clinical demyelinating events. But when the current diagnostic criteria are revised, do you expect some of them may be incorporated into the core clinical demyelinating events?
I think that's possible. Yeah, I think particularly the meningoencephalitis phenotype is one that we do encounter sometimes. I think you have to be careful because there's lots of different causes of aseptic meningitis and you could have some low positive results. So usually, you know, we have to kind of have that balance of phenotype creep. But many of the cases I've seen with meningoencephalitis, either they presented with meningoencephalitis and then they evolved into an ADEM type phenotype. So the initial MRI, the initial presentation was more of a meningoencephalitis and then they evolved into an ADEM, or they just had an episode of meningoencephalitis and then they went on to have optic neuritis or myelitis. So I do think there is a phenotype and there's potential for expansion, but we have to be very careful as we do that we don't expand it too much and are, you know, avoiding false positives too. So I think there's a balance and you would need probably some supportive criteria and, you know, have stricter requirements depending for some of those rare phenotypes, I think.
Thank you.
Hi, Eoin. About patients with the raised intracranial pressure, you said that sometimes it can be confused with idiopathic intracranial hypertension. What is the mechanism in those patients? I mean, why do they get high raised intracranial pressure?
we don't know. I think for sure there have been some recent reports of this in neurology. I think from Ben Greenberg and his group. I don't think we know the exact mechanism. You know, there is a lot of leptomeningeal involvement in MOG, so maybe there, you know, some blockage of the arachnoid granulations or something like that that leads to increased intracranial pressure. So I'm not sure we know the exact mechanism. The other thing I'll say is that some patients will have bilateral optic disc edema where it's not papilledema, but it's from the optic neuritis. And that's also, those patients go in and they complain of a headache. And sometimes they also get misdiagnosed as idiopathic intracranial hypertension. So there's two aspects to it, because if you have a bilateral optic neuritis and you have bilateral optic disc edema and you have a headache, then with eye pain, then sometimes they can be also misdiagnosed as idiopathic intracranial hypertension. So I think it's something that we need to educate neurologists on, make them aware of. And then we'll probably have to try and learn more with additional radiology studies or other things to try and figure out what's the exact mechanism of the increased intracranial pressure.
Thank you.
Yeah.
Great question. Thanks, Ben. Sorry. Yeah.
Thank you for that talk. About MOG antibodies and in aquaporin 4, both of those are, one is a demyelinating disease and the other one is a astrocytopathy. How do you explain the involvement of gray matter in both these diseases that you see on MRI?
Yeah, it's very interesting, isn't it? I don't know that I can fully explain it. You know, there are oligodendrocytes within the gray matter, so it's possible that there's some targets there. And one could wonder if there's something coming in from the central canal and the inflammation is spreading outwards that way. And, you know, we get deep gray matter involvement. Maybe there's inflammation coming from the ventricles kind of inward towards those regions. But I don't think we have a full explanation of that yet. And we see it, I suppose, in both disorders. We can see lesions in the thalamus and lesions in the gray matter. And I don't think we have a good sense. With aquaporin 4, I suppose there's quite high aquaporin 4 expression around those circumventricular organs, so that may explain some of those lesions involving some of those gray matter regions around the ventricles, but I don't think we have a good sense yet for that in MOG. So yeah, lots to learn probably, but excellent question, yeah.
There's one more question.
Thank you for that excellent talk. In the MOGAD-related encephalopathy syndromes, is there any overlap clinically and especially in the antibody profile with other autoimmune encephalitis syndromes?
Yeah, this was covered a little bit, I think, by Professor Fujihara and Professor Kim earlier, that there does seem to be a link between MOG antibody-associated disease and NMDA receptor antibodies, particularly with the cerebral cortical encephalitis. And sometimes the initial syndrome can look like NMDA, and then they later develop an optic neuritis and have MOGAD, or vice versa. So it can go either way. So I do think there is some overlap with NMDA. You know, there, like Professor Kim said, for the when you've got dual positivity with MOG and aquaporin 4, usually the aquaporin 4 is really high and the syndrome is more suspicious for aquaporin 4, and the MOG antibody is just a low positive, so maybe a false positive. So so I think it's hard to tease apart. You know, there's been, I think we've seen some cases where GFAP antibodies and MOG antibodies coexisted, so there's probably rare case reports where there can be multiple antibodies, but NMDA is the main one that you need to look out for and test, particularly in the cerebral cortical encephalitis phenotype.
Thank you, Professor Flanagan. I think that was a very comprehensive talk, very important for Sri Lanka, because in Sri Lanka we have limited facilities for serology and MO and MOG, and we rely very much on MRI to differentiate some of these patients. And I think your talk will help us towards that. Thank you very much once again.
Great. Thank you so much.
I think my co-chair, Dr. Harshri, will take over from this point.
So we'll come to the last talk of this symposium on MOGADs, and it will be on dilemmas in management of MOGADs by Professor Lekha Pandit, Director of the Center for Advanced Neurological Research, Niti University, Karnataka, India, and she's also current secretary of the Pan-Asian Committee for Treatment and Research in Multiple Sclerosis. Over to you, Professor Pandit.
Thank you very much. I know I'm at the tail end of a very long session and you are just awaiting your lunch. Some of the material has already been covered and some of the slides even may have commonality, but I want to approach this disease from a pragmatic point. As a clinician researcher living in a low middle income country, just as yours, where everything that we do has to be very much goal oriented in terms of cost effectiveness. So I have no disclosures for this particular talk. So the clinical diagnosis, I would insist, for people like us who work in non-specialist environments in the midst of general neurology, clinical diagnosis is very much at the core of differentiating variety of demyelinating disorders. Why do I say that? That's because we are very comfortable with the course and evolution of MS, for instance, now with so much of information available to us. We know that aquaporin 4 and antibody-mediated disorders, once you diagnose it, you have a very straight, clear course of how you should manage these diseases, which are extremely destructive. Invariably, it's going to relapse, and we need to make sure there are no more attacks. But MOGAD is such an uncertain disease with an uncertain clinical course and treatment options that we have to be very wary about when you're going to suspect this disorder, and especially as, like in Sri Lanka, there is very little options for doing MOG IgG testing and also antibody testing. So therefore, one should prioritize whom are we going to be investigating. So I would say that the phenotype, the attack severity, and the recovery pattern of these demyelinating events are extremely important for us to make these decisions. For example, the phenotype, if you take optic neuritis, the attack severity gives you an indication, most often than not, that it is an antibody-mediated disease or MS-like. Recovery patterns are extremely important in terms of residual visual disturbance, which more favors an antibody-mediated disorder and more often an aquaporin 4 antibody-mediated disease than MOGAD. Then age and gender at first attack is extremely important because NMOSD as a phenotype is extremely unlikely in children, while MOGAD, on the other hand, which shares so much of common clinical and radiological features, tends to be quite frequent among children. And I'm an adult neurologist, but I get to see significant number of patients with pediatric onset disease as well, so we need to be sure. And then again, a peripubertal spike in demyelinating events also favors that it could be an attack of pediatric MS. So we need to have a plan in mind at this clinical setting. The finer nuances of criteria and radiological features may not necessarily be available to us at that point in time when we are seeing a given patient. And the third and most important thing is the evolution of disease. As someone was saying, if the person seems to have a slow and definitive progression between attacks, I think we are probably moving away from antibody-mediated disorders and more towards MS-like disease. And I want to caution here that when you see patients and you have imaging, most of the imaging helps you during the acute phase of an attack. All this lovely radiology that was presented are those of patients who come in the acute phase of the attack, and more often than not during the first attack. In fact, the clinical criteria for MOGAD also is based on the first attack that you see. But many of us know that most of our patients are not likely to reach a hospital with a specialist care during the peak of an attack illness. And so therefore, a tumefactive lesion may appear to be coalesced multiple short segment lesions, for instance, and we may not have serial MRI to see what has been the course or evolution of the disease. So it's extremely important for us to know that we cannot absolutely be dependent on imaging and what it gives us. Biological testing, I'm sure you have Euroimmune testing available, fixed cell-based assay. I could easily tell you that when you compare the aquaporin 4 antibody assay is quite robust. It may be mildly less sensitive in terms of comparing it with the live assay. We have done these comparisons in my lab where we have live assays for both MOGAD and aquaporin antibody assays. And so if you get an aquaporin 4 antibody positivity in a live assay, in a fixed cell-based assay, you can very well believe the outcome of that test. But that is not so the case of MOGAD. And you know all those the different perils that we face in interpreting a MOGAD result. So So some of the talking points here quickly I would say is diagnostic uncertainty. I think just like our teachers told us, is it epilepsy? Is the first attack epilepsy? Is every fall considered to be epileptic? So is it MOGAD is something which I would say we should ask. Will it withstand review? And I have had these issues early on when we were trying to understand more about MOGAD, the clinical radiological picture. An unpredictable clinical course, and there were several in the audience who were asking, can we diagnose monophasic disease at onset, or how do we know that they will relapse? And I can present to you some of the current literature on short cohorts of cases which seem to suggest certain findings which may offer us some reliable pointers. Then, of course, coming to treatment options, acute treatment. When you try acute treatments conventionally, there is a point at time which we should recognize that we need to escalate treatments because the outcomes may not be very satisfactory. And then maintenance therapies. What are the different maintenance therapies that we have used in MOGAD? How long do you treat? And also is again a big question. I'm not saying that I have answers for all, but these are the obvious questions that face you when you see a patient with MOGAD. So just quickly look at a case, something similar that Ho Jin showed you, because this is something that we see all the time. Patients come to us with acute, for example, typical example is an acute painful visual loss diagnosed as optic neuritis. Already they have done the MOGAD testing, 1 in 10 positive, and the patient has been labeled as having MOGAD at the time when I see the patient. So I use the pointers that are normally used in a clinical setting. You need to review the patient's history. So history is reviewed, and there's steroid responsive intermittent weakness of the right lower limb for several years. And recently there is an evidence of progression, and especially in a postpartum setup. So everything points to a progressive disease, and obviously the MRI was very typical of MS, short segment lesions, and isoelectric focusing unambiguously shows her to have a CSF-specific oligoclonal bands. And so the question is, when you go and apply it to the clinical criteria, the phenotype of an optic neuritis, we have quickly, like a knee-jerk reaction, rushed to do an antibody testing, when actually exclusion of other causes, evaluating the radiological features and other things were very important. And in this setting, it was clearly not indicated. We need not have done an expensive test, which the patient clearly did not require. And in a non-specialist setup, it would add more confusion, and we would go down a rabbit hole in which your treatment decisions are not based on a sound basis. So a positive predictive value that we were talking about simply goes down if you keep flinging more IgG testing in every clinical setting, and then come up with answers for which we don't have any quick resolution. So this is an interesting patient where I had the reverse scenario of this. Way back in 2013, we saw this patient referred to me by a colleague who had treated her as multiple sclerosis with recurrent attacks of recurrent optic neuritis, brainstem attacks. And at that point in time, she had all these lesions, which naively, which we believe pericallosal, periventricular lesions. There was an atypical brainstem lesion, which I did not give much importance to. Neither did I give much importance to the fluffy, irregular lesions that you're seeing. So we treated her with interferons, intramuscular ones, then thrice a weekly. Avonex was once weekly, and Rebif thrice a week, and she did not improve. In fact, she had more number of attacks. She completely refused to come back to us in clinic. She would get her local physician to give her short doses of IV steroids, or she took oral steroids, and that gave her best results. So she had a very bad relapse when she had myelitis, and she came to me with quadriparesis when she needed hospital admission, and I have very much subsidized care and medication, so patients will come back because of the lowered cost of therapy. So at this point in time, she had an extensive longitudinal extensive myelitis, and you could see all these mustache-like features very prominent lesions in the splenium, which Eoin was talking about. It's a typical looking lesions in the brain. And at this point, we realized that she had, and I actually went back and checked her MRI of 2013 to see did I miss any lesions in the cord at that point in time, which was not so. And then at this point in time, we have had samples which we had kept in our biorepository, which we were able to send to Professor Fujihara's lab, and it came out as MOG positive and very high titers. And she remained on mycophenolate mofetil after a short bridging therapy with steroid, and she did very well for several years. But in India, as I'm sure in Sri Lanka, patients don't like taking medications. So at some point in time, she decided she didn't want to take anything. So she stopped her medication. 4 months later, she developed very severe headache, altered sensorium seizure, and she had a very bad tumefactive lesion from which she improved. And then she went back to taking mycophenolate, but she didn't completely recover in that she had significant residual deficits. She had a significant cognitive impairment, emotional lability, dysarthria, stance, and gait ataxia. And you can see her MRI in 2023, even though she remained in remission, there are a lot of new lesions, like Eoin was talking about in terms of the corpus callosum lesions have increased, and there are more lesions now in her brain than it was originally there when I showed you. And these are persistent. So chronic MOGAD MRI are not necessarily the kind where you find lesions disappearing. I'm sure there's a small percentage of them in whom lesions persist or accrue over time. So that is something to be remembered. And it also tells you about the nastiness of this disease in a subset of patients in whom lifelong immunosuppression seems to be needed in the way you need for aquaporin 4 antibody-mediated disease. So there's several lessons to be learned from this, and also the underscoring the point you cannot generalize MOGAD. You know, one person is not the same as the other. On the other hand, an extremely different case was when I saw child was in high school when I first saw him. He came to me with fall accompanied by loss of consciousness. He had a history of maxillofacial trauma, which was operated on. 2 weeks later, he developed fever, and then he developed acute paraparesis and urinary retention. He was very conscious. There was no encephalopathy picture. I want to tell you that because when I show you the scans, you may wonder. So he had grade 3 to 3/5 paraparesis, and he had a very longitudinally extensive myelitis. And you also had a lot of ADEM-like MRI picture in the brain, which is again a feature that you can see in MOGAD. I did not have any antibody testing at that time in 2012, but all our samples are stored, as I said. And so years later, when I developed my lab, in my own assays, I checked his aquaporin 4 antibodies, and it was significant. It was significantly positive. We were doing a comparative study between live and fixed assays. And then this boy has remained on follow-up with me, at least calls up once a year. And when he came to see me in person in 2021, I did his MOG antibody testing, which was still very high, though he has never had a single attack in the last 10 years or so. So that's the extremes of MOGAD, you know. It's like shifting sand. You do not have a unified approach to management. So just to summarize a few of the therapies, acute therapies, again, we have a dilemma. Do you give IV methylprednisolone followed by a short oral taper? Anywhere from 1 month to 6 months is what different groups have advocated, and there are also those who do not want to give an oral taper. And there are some who would like to consider an equivalent of oral prednisolone, which seems a bit draconian, but apparently you can make patients swallow that many tablets, not Indians for sure. Plasma exchange, yes. When your steroids do not work, we need to go immediately on to plasma exchange, and I will give some information on that as well. And then there are sequential therapies you can give, or combination therapies that have been advocated. And then, of course, Professor Fujihara showed us the tocilizumab slide, which I also am going to show you from a different perspective. So acute treatment, how early should it be? And this is a very nice poster that was later on got published by Kalish et al., the Berlin group, in which they saw that patients who received had acute optic neuritis, most of them were acoporin-4 antibody mediated. There was some MOG as well. But the bottom line was that treatment had to be so early. There is significant failure of visual improvement if it was treated as delayed as 4 days from the onset of an acute optic neuritis. And of course, the residual visual loss became even more severe as the delay, as time to treatment was delayed. And currently, there is this Eoin study which is on, which is a worldwide network of centers which were addressing the same issue, and we are part of that study as well. Time to treatment with high-dose steroids within 30 days of the first attack of optic neuritis. So it gives you an indication as to the urgency of treatment. And if the IV methylprednisolone does not work, you need to go on to the next step. So you and I know that plasma exchange is expensive, IV steroid not so much. So when persons come to you with severe myelitis or severe visual loss at peak, I think you need to sensitize them that within the 3rd, 4th day, if there's no visual recovery, you need to plan this investigation for you, which you need to find the money. So you basically, by the 5th day, patients should be ready to translate into this treatment. And I don't know any of the foreign faculty know that, but all of this comes out of the pocket without any insurance cover for that particular person. So sensitization is so important to being able to translate treatment, because time to plasma exchange again matters. So this material that I want to present is from Dr. Chen's group in Mayo Clinic. And they have looked at the outcome of MOGAD, apart from other forms of optic neuritis, and they found that if you treat them early, when they have counting finger level of optic neuritis, visual loss, and they've had their usual IV methylprednisolone, within a period of 2.3 weeks of treatment shifting to the plex, they found visual recovery was perfect in all the patients, with the exception of one who only could take plasma exchange 6 months after the visual loss, which again goes to show that intervention and timing of intervention is so crucial to visual recovery. So coming to this tocilizumab, the reason why I put up this slide, as Professor Fujihara did, was the fact that they were able to recognize this as part of MOGAD. And this patient, again, like my patient had come, one of my patients who came with a trauma had developed evidence of somnolence, which they mistook for brain injury. And then in the course of that treatment of acute brain edema with conventional means, they found that he developed longitudinal extensive myelitis, which is when the primary pediatrician, decided to check MOG antibody. And that was crucial, because irrespective of the anti-edema measures that were given, the steroids and the plex that the patient was getting, it was tocilizumab that literally saved the patient. There were just 2 injections given. And I bring tocilizumab to your mind because it's feasible in our countries, especially having had COVID-related medications coming into the country. We have a lot of generic tocilizumab in our country, and you can imagine it makes sense to give tocilizumab, especially because I think Professor Fujihara's group and others have shown IL-6 levels increase in the CSF in these patients, and IL-6 blockade apparently is very useful and a very novel way to treat patients. And this patient didn't stop there. They continued to give him or her plex. Outcome was not so good. Neuro rehab, child was going back to school again, and then developed another encephalopathy when the MOG antibody titers, which had disappeared, had come back again. Child had to go back onto treatment. So this appears to be a longitudinal, lengthy process in this young boy. So MOGAD clinical course, monophasic versus relapsing. Do we have any evidence that helps us to suggest that it may remain monophasic or not? So I personally feel it depends on the duration of follow-up. I know Eoin said 50% of patients remain monophasic. I'm not sure at all. I think the longer you wait, you find a larger number converting to the relapsing phase. So I would say anywhere between 60 to 80% of patients on long-term follow-up are likely to have events, maybe after a lengthy period of a monophasic course. Median time to relapse on an average may be around 5 months from studies that I've just listed down. And it could also depend on the age groups. They're not quite sure whether it is relapsing more in a pediatric age group or in adults, because there are small cohort studies which suggest both. And then, of course, prediction by serostatus. Professor Comey was asking that. More than 50% can remain seropositive, but still there may be those amongst them which will remain seropositive and have a monophasic clinical course. Around 10% can have a fluctuating course of being positive, then negative, then positive again, or vice versa. But one thing they found, Huda found from UK, was that within 6 months after seronegative conversion, the chances of remission, chances of a relapse appear to be less. So that's an indicator that maybe you could continue to monitor with serology in those places which can afford to do this sort of monitoring of patients on a real-world basis. And maybe you may be able to offer in a segment of patients some assurance that they may be disease-free for the time. But then there are exceptions to every rule. So I just wanted to talk a little more about this particular study. There were 76 patients observed, but as you can see, the ones who had a monophasic course were observed for shorter periods of time. So that kind of already puts a question mark as to what would have happened if we had seen them longer period. So what they found was steroid treatment, when it was given for a longer period of time, that's after the initial treatment, the taper was prolonged. When the patient had a phenotype like transverse myelitis, when the patients were of male gender, they found that they were more likely to remain monophasic during the period in which they were followed up. Same way, increased latency to the next attack, the patients were of male gender and had myelitis as a phenotype. Seronegative conversion may be associated with lower relapse. So that's what they found in this particular cartoon. The patients who remained seronegative during the period of their follow-up, they tended to show more of a remission phase than relapse, but of course there were exceptions. So that again tells you that we don't have a real strong or concrete answer from any of these parameters. And you cannot afford to be doing serological testing on patients in our setup on a long period, unless it is a funded project. So treatment of relapsing MOGAD typically reserved for those with 2 or more attacks. Having said that, I would say young children who come to you with bilateral significant optic neuritis and residual visual loss, you may be tempted to actually treat them with immunosuppression, at least for a period of time, because you worry about a recurrent attack and the inability to have good vision. And no proven treatments with class 1 evidence. We borrowed from the observed data from NMOSD patients, mostly. So maintenance corticosteroid, as defined by a nice paper from Sudarshini Ramanathan, currently based in Sydney, Australia. They had come up with a very nice paper which defined maintenance steroids. And then, of course, non-steroidal immunosuppressants like mycophenolate, azathioprine, and rituximab, not so popular, but these are the other modalities that you can use for getting immunosuppression over a long time. And of course, maintenance IVIG is also being used as a modality. Let's quickly look at the results of these. So maintenance steroid as an attack prevention strategy. Steroid in the long run is very unpopular among the young children for health reasons, obviously, and among women for the fact for the Cushingoid and other related side effects, and they're very, very poorly compliant in my part of the world. In fact, currently I'm settling a dispute between a husband and a wife. The wife refuses to go for some marriage festival, which is very big in India, because she doesn't look good and she's on steroids. So therefore, apart from many other reasons, we may have even marital stress as a factor preventing people from taking maintenance steroids. But having seen that, the interesting point is that as the patients dosage of steroids are reduced, the chances of relapse have increased in these patients over a period of time, and with significant relapse after the steroids have been stopped in both adults and in young children. And you find that the frequency of relapse is especially so if the patients initial bolus of steroid, IV methylpred was stopped without any oral taper, and also if the oral taper happened in less than 2 months. That's what the study shows. So the message that you take home probably is that there has to be more slower tapering, especially if the initial event was a monophasic event. You may want to give up to 3 to 6 months, and at least a minimum of 3 months in patients who have had the initial IV methylpred. So what we do is that we follow what Rendell and others have done in that. This is a very busy slide, but I just want to tell you that after the initial attack, monophasic attack, and you give them a short course of steroids for 3 months, what we do is we add on mycophenolate and azathioprine in those patients who had a relapsing event. In that way, we were able to maintain them on a fair degree of remission. And you find different sorts of response in these patients. The ones who've had recurrent optic neuritis, for example, most of them who tried to go off the medication developed another attack. And there are also those like recurrent myelitis, which is a very unusual form of phenotype for MOGAD for reasons I don't know. And there has been such a huge interval between the first and second attack that patients do not really want to be on medication. They do not take any and they remain well. Perhaps they have a very indolent form of disease. And then, of course, you have the NMOSD phenotype, which appears to be quite aggressive in terms of their relapse after patients have stopped the immunosuppressant, the typical example I had shown you. And finally, maintenance intravenous immunoglobulin, again a nice study from Mayo, and they have looked at a large group of patients in whom 59 of them had received maintenance IV, a very few as first line, but mostly as failure of immunotherapy or inability to tolerate the adverse effects of immunotherapy. So annualized relapse rate overall was reduced, but a third of them had at least one relapse while on maintenance therapy, and a third of patients had to have, again, concomitant immunotherapy alongside IVIG. And dosage required is pretty high, after the 1 gram per kg per body weight monthly. And that's pretty steep cost-wise. But my colleagues, especially pediatric colleagues, believe that is a very good alternative to giving steroids as disease-modifying agents. And I believe they have subcutaneous immunoglobulin available, so it does not necessitate the child to come back to the hospital setting. And also, it protects against infections when you're on IVIG, so the trigger for the MOG relapse also comes down. But as I said, it's a popular alternative, especially if the patient can afford it. So, from summary and some future directions from my point, unlike MS and aquaporin-4, I mediated NMOSD, where we know the course, where we know the directions, we are not necessarily in very certain territory when it comes to MOGAD, and very challenging despite good diagnostic criteria. The clinical spectrum of MOGAD continues to unfold, and on one hand, we say, okay, let's not test disorders which are outside the phenotype, but at the same time, we discover the extension of the phenotype by testing MOGAD in situations which are not bound by those clinical phenotypes. And I think brain edema is a big feature, BIH-like picture we have seen in patients who have come to us with headache, white matter lesions, looking like radiologically isolated syndrome, who had tortuous, kinky optic nerves and flattened optic poles, typical of orbital poles, typical of the BIH radiology findings, with high opening pressure, who were MOG positive. So I think we should keep our minds open and intervene, especially when you know IL-6 blockers can save lives. We should keep our mind open and consider one situation against another. So clinical course is very unpredictable, as I said. Treatment strategies have to be individualized. And of course, there are ongoing clinical trials on these molecules, which Professor Fujihara mentioned. And I would stop on a cynical note to say that these drugs are never going to reach us. You'll have to wait for the patent to be over when Indians will make good generics and supply them to you as well. So with this, I would stop. And thank you so much for your patient listening. I'm happy to do mock testing for you. In case you have patients on whom you want live cell-based assays, you just need to send them to my lab. That's my contact address, and I'm happy to do them free of cost. Thank you. Thank you very much.
Thank you, Professor Lekha Pandit, for that excellent account on challenging treatment of MOGAD. I'm sure we can entertain one or two questions from the audience on this. Yeah, Dr. Shania. Yeah, Tash. After that, Dr. Shania.
Thank you for that comprehensive talk. In a patient who relapses, how long would you continue maintenance therapy for?
So several factors will determine that. What was the primary phenotype and how well did he or she recovered from that first insult? And persons who have had, as I said, it's very easy for me to make the decision when you have had significant visual disturbance after bilateral optic neuritis. Since we do not have any clear indications as to who will relapse or who will not, I would at least counsel them to take for a minimum period of a year plus. And if the patient is happy to continue, and we dialogue periodically, there are those who have had relapse again after stopping the immunosuppressant, and there are those anecdotally who have discontinued medications and remained well. But I would say when the person's had a residual deficit from the first attack and has another attack in the same territory, I would say let's go easy on tapering and stopping immunosuppressants.
Dr. Shania.
Yes, this question is actually relevant to our part of the world where the MOG antibodies are not freely available. We have seen some patients who are coming with myelitis-like picture, yet they have CSF which look very infected with a lot of neutrophils, lymphocytes, high proteins, and a bit of sugar drop also. So we think in line of some infective myelitis, but we have seen and read that in MOG disease also they can have pretty cellular CSF. What's your experience on that? Have you seen such patients which actually that may delay us starting immunosuppressants in such patients?
So conventional teaching is patient's myelitis with raised protein and cellularity and reduced sugar, it's infective unless otherwise proven. So I have to treat aggressively. Most often than not, I've had a very similar case recently, young boy, who had longitudinally extensive myelitis, who had pleocytosis, neutrophilic initially, and then lymphocytic, on whom TB-PCR was negative, but responded excellently to antituberculous therapy. So when you have patients who come to you with CSF evidence of, you can even send for metagenomic sequencing and all that of the CSF, there are a lot of those tests available, but infection unless otherwise proven.
Small thing, have you seen MOG positive patients with cellular CSF at any point?
Yes, of course. We
with
do
high
get
proteins also?
Yes, you can, especially if the initial attack was a longitudinal myelitis. Pleocytosis is not uncommon. Raised protein is not uncommon. But sugar dipping, no. I would draw full stop on that sugar dropping, though technically speaking, some viral infections can also produce a sugar drop, but then in our setup, it's always safer to treat, especially for tubercular meningitis. I cannot emphasize it more.
So, in the interest of time, I think we'll conclude this session. Is there any more question? One more question, sorry. Yeah.
Hello, Prof Pandit, a small question on tocilizumab. We had a patient who had the MOGAD phenotype. Unfortunately, she didn't have the, she couldn't afford serology, so we based on the clinical diagnosis and treated her with toci. And she responded well. And for the continuation, what is the regime you use? We were basically using the imaging findings to monitor the gut enhancement to continue the treatment monthly.
So here, in that example, I myself have not used tocilizumab, but that was given as during the period of acute edema, more of a anti-inflammatory agent in view of the IL-6 levels having gone up, and we know for historically that IL-6 levels tend to be high in MOGAD. But otherwise, the mainstream treatment of MOGAD would be along the lines in which even that child was treated. He was given Plex, then maintenance IVIG, or any other immunosuppressant. So why is it not possible to do fixed cell-based assays in your part? Euroimmune testing is so simple. It is...
she couldn't afford it.
Oh, okay. Right.
Thanks.
So thank you, and we conclude this symposium, and let us show our appreciation to all 4 speakers who did excellent job in challenging diagnosis of MOGAD. So we'll break for lunch now and meet at 3 o'clock, so 45-minute lunch break from now. Thank you.